But it is an emergency, and it's an emergency that we miss all too often. We find that in our busyness of caring for a person, we can miss what is underlying going on with this human being lying in the bed. And we are called to serve that person who's suffering. We're called to take care of that human being who's on life support. And we're so preoccupied with the beeps and the buzzers and the way that the heart rate and the pulse oximeter is working that we tend to forget about the magnitude of what's going on inside of their head. And so as a young physician, before I had all this gray hair, I would be so driven to control every single aspect of what was going on with the person that I paid attention from the clavicle to the diaphragm most, the cardiopulmonary physiology. And I think that in my desire to control every little aspect of the patient's cardiopulmonary physiology, I really started to discard the importance of the human brain. And it was 5-10 years into being an intensivist that I started seeing people back in clinic and their brains weren't working right. And they were not being able to go back to their job. And they were telling me that they were getting a divorce and that their wife was no longer understood them anymore. And they couldn't help their child with the math homework that used to be so easy for them. And it was just heartbreaking. I started listening to these stories and wondering, what is going on? Why are these people? Because I was their doctor in the ICU and they came in with a kidney problem and I took care of their lung problem. But now that's not their complaint. Their problem is now a brain problem. They didn't have a brain problem before. What we found over and over again in the literature, in our own studies, is that it's really about the duration of delirium that is the most predictive of death and length of stay and cost of care and acquired dementia. So it's that how long is that brain not doing well? Because when the brain is in delirium, you're losing brain cells. You have abnormal neurological function, and some of these brain cells are going into apoptosis or programmed cell death. We have a paper with Arjen Schluter on this topic where many delirious patients are in an acute encephalopathy, and acute encephalopathic patients are delirious. One of them is a clinical phenotype of how the patient's doing, and the encephalopathy gets at what's the cause behind it. It's a global problem how we respond. Sometimes people say, well, what are we going to do with the information? And I always like to tell people, well, you can always run through a simple checklist in your brain. I use a mnemonic that we invented called the Dr. Dre, which is diseases, drug removal, and environment. Well, let's run the Dr. Dre. What diseases could be creating this problem? What drugs should we remove, not add? And then what environmental things like sleep, wake, eyeglasses, hearing aids, light in the room, and mobilization, and family presence. Those are really the environmental things that control so much of the delirium. So that's a quick way of answering somebody who says, well, how will we use the information? Very, very practically, every day you will use this information.